So good evening, everyone. It is indeed a pleasure that all of you have joined today in this advocacy group today, and we are doing this as a part of an awareness program for rare disorders. It's my pleasure to introduce Mr. Saurabh, who is the founder of the Rare Disease India Foundation, and he has done a lot of work, and a lot of tremendous path-breaking initiatives have been taken by him for the same, and he's doing his best to help all the children with rare disorders. And as they say that even if the disease is rare, the hope should not be rare. So with that message, we shall begin now the program of this rare diseases today, and we will be discussing a panel in it. But before that, I would like Mr. Saurabh to take over and introduce himself to you.
Yeah, very good evening, everyone. I am Saurabh Singh, co-founder and director, Rare Diseases India Foundation, RDIF. It is my pleasure to welcome our eminent speakers, panelists, moderator, and all the attendees today who are watching us from different corners of the world. First of all, I would like to inform you that unfortunately our chief guest, Mr. Rashid Merchant, could not join because he is suffering from COVID from last couple of days. We pray to God for his speedy recovery. And now I would like to appreciate Sanofi Genzyme for supporting us for this great noble cause. I also thank to our strategic partner ACMERI to come forward. Rare Disease India Foundation is a patient advocacy group. It is established in 2019. This is a non-profit organization which works for the benefits of the patients and to raise awareness about rare disease in the country. Rare disease. This word is self-explanatory. As we all know that rare diseases are very few in numbers, and mostly it is genetic. Only 6% to 8% of population of India is affected with rare diseases. 72 to 96 million people affected by rare diseases. There are many challenges in rare diseases. Either there is no treatment available or the treatment is unaffordable by an individual, which generally comes in crores of rupees. Second challenge is early diagnosis of the disease. Lack of awareness about rare disease, including doctors and the patients too. Government does not support fully in these diseases. Patients are slipping into the joy of death, whereas the treatment is unavailable in this world. Parents are bound to watch their child dying every day. We all know that. In the month of March 2021, the government of India has formulated a revised rare disease policy, but that too is very much not effective, especially for group 3 diseases, which includes lifetime treatment, but cost is very high. To discuss in detail about these issues, today we have the best speakers of India from different renowned hospitals of the country. First of all, I would like to welcome Professor and Chairman, Dr. Ratna Duapuri from Sir Gangaram Hospital. She has a very vast knowledge about rare diseases, and she has been treating the rare disease patients from so long. I also welcome Professor and HOD, Dr. Ashok Gupta from SMS Hospital, Jaipur. He is also an in charge of rare disease division from Government of Rajasthan. Our another panelist is the young and dynamic Associate Professor Dr. Priyanshu Mathur from SMS Hospital, Jaipur. I welcome Associate Professor Dr. Suvarna Mangal from MGM Hospital, Aurangabad, Maharashtra. She has also been treating patients with rare diseases. I welcome Director and Chairman Dr. Rajesh Kumar from Rani Children Hospital, Ranchi, Jharkhand. He is very renowned doctor of Jharkhand who has a very long experience treating the pediatrics. And last but not the least, I most welcome to our moderator, Associate Professor and Consultant, Dr. Veronica Arora from Sir Gangaram Hospital, New Delhi. She is also treating rare disease patients from very long. Over to you, Dr. Veronica.
Thank you so much, Saurabh, for the kind introduction. And now we will be listening to a beautiful patient story through a video, and it is highly heart-wrenching. I hope all of you like this.
हेलो, मेरा नाम लतिका दुआ है। मेरी उम्र 24 है। मैंने कॉलेज ऑफ आर्ट्स से फाइन आर्ट में ग्रेजुएशन कंप्लीट की है। मेरी हॉबी ड्राइंग, पेंटिंग, स्केचेस है।
हेलो, मेरा नाम मयंक दुआ है। मेरी उम्र 22 साल है। मैं नॉर्थ डीएमसी मेडिकल कॉलेज हिंदूरा हॉस्पिटल से एमबीबीएस थर्ड ईयर की पढ़ाई कर रहा हूँ। मुझे क्रिकेट खेलना, पढ़ना और ड्राइव करना बहुत पसंद है।
लतिका को मैंने देखा 2003 में, इसकी बैकबोन में बैंड है। मुझे लगा कि इसकी रीढ़ की हड्डी टेढ़ी क्यों हो रही है, तो मैं इसको लेकर सेंट स्टीफन गया। वहाँ पे डॉक्टर दिखाया तो डॉक्टर ने कहा आप इसका इलाज यहाँ पर नहीं है, आप एम्स में जाइए। हम एम्स में गए थे। वहाँ पे डॉक्टर ने हमें एडवाइस दी कि इसका एक टेस्ट होगा MPS टाइप 1। हमने वो टेस्ट कराया। टेस्ट की जो है बाहर गया था इंडिया से, काफ़ी खर्चा आया उसमें। तो लतिका को पॉजिटिव पाया गया। डॉक्टर ने कहा अपने बेटे को भी लेके आइए, उसका भी टेस्ट कराएंगे। बेटा भी पॉजिटिव पाया गया।
MPS टाइप 1 एक जेनेटिक बीमारी है और ये बहुत ही रेयर है पूरे वर्ल्ड में। इसमें एक एंजाइम की डिफिशियंसी हो जाती है जो कि बॉडी में प्रोडक्ट एक्यूमुलेट कर जाते हैं और ये जॉइंट स्टिफनेस और जॉइंट पेन करते हैं। ये हार्ट प्रॉब्लम्स भी कर सकते हैं और मेंटल रिटार्डेशन भी कर सकते हैं। एम्स के डॉक्टर ने हमको एडवाइस किया बोन मैरो ट्रांसप्लांट के लिए। 2004 में मेरी बहन लतिका का बोन मैरो ट्रांसप्लांट हुआ एंड 2005 में मेरा बोन मैरो ट्रांसप्लांट हुआ। बट बोन मैरो ट्रांसप्लांट के बाद भी कंडीशन पूरी तरह इम्प्रूव नहीं हुई थी।
कुछ हद तक आंखों की समस्या ठीक हो गई थी। डॉक्टर ने कहा अगर नहीं हुआ तो इनकी कॉर्निया भी चेंज कराना पड़ेगा, जो कि ठीक है। अब फिर इनके हाथ पैर में दर्द होने लगा, सिर में दर्द, तो इनको एक्सरसाइज की ज़रूरत थी। तो फिजियोथेरेपी के लिए एम्स में आते थे, आए दिन हर हफ्ते, कभी ऑटो से कभी बस से। पैसे की प्रॉब्लम, तनख्वाह इतनी नहीं थी। जैसे तैसे मेरी वाइफ को समझाया कि हिम्मत मत हारो, बच्चों को स्ट्रॉन्ग बनाना है, इनको नहीं बताना कि बच्चे बीमार हैं। 2008 में हमारी आशा की किरण जागी। हमें खुशी हुई, एंजाइम थेरेपी ने चैरिटेबल द्वारा हमें दवाई देना शुरू की, जो कि दवाई हमें मिलती रही। उससे बच्चे इंप्रूव करते, उनके हाथ पैर भी ठीक होने लगे और उनके कोई दर्द नहीं लगा। 2018 में मैंने ऑफिस में लिख के दिया, तब जाके वहाँ से मुझे सपोर्ट मिला, वहाँ से दवाई शुरू हुई है।
13 साल हो गए इनको दवाई मिलते हुए और अब थोड़ा सा लगता है कि बच्चे अपना फ्यूचर खुद बना सकते हैं और पढ़ भी रहे हैं अच्छे से, आना जाना भी अच्छे से है इनका और कोई दिक्कत नहीं आ रही अभी।
मेरी बेटी जो है PFA कर चुकी है, आगे पढ़ना चाहती है। बेटा मेरा MBBS कर रहा है, जो कि थर्ड ईयर चल रहा है। मुझे खुशी है कि बच्चे मेरे पढ़ रहे हैं। मैं उनको कभी महसूस नहीं होने देता कि आप जो है बीमार हो।
हमारे फैमिली और फ्रेंड्स ने हमको काफ़ी इमोशनली और मेंटली सपोर्ट किया, हमको कभी अकेला महसूस नहीं करने दिया और हमको बहुत स्ट्रॉन्ग बनाया। और आज हम ये MPS के अगेंस्ट लड़ाई लड़ भी रहे हैं और जीत भी रहे हैं।
बचपन से ही मुझे ड्राइंग का बहुत शौक था। स्कूल टाइम पे मुझे ड्राइंग में बहुत अवार्ड्स मिले हैं। फाइन आर्ट में ही मैंने अपनी ग्रेजुएशन कंप्लीट करी है। मैंने अभी मास्टर के लिए भी अप्लाई किया हुआ है। मैं आगे टीचिंग लाइन में जाना चाहती हूँ। मैं बच्चों के ज़िंदगी में रंग भरना चाहती हूँ।
मुझे मेडिकल फील्ड में काफ़ी इंटरेस्ट था और मुझे डॉक्टर की पर्सनैलिटी मुझे काफ़ी अच्छी लगती थी, तो मैंने अपनी डिग्री भी MBBS परस्यू करी और आगे मैं PG कोर्स करके एक अच्छा डॉक्टर बनना चाहता हूँ, लोगों की हेल्प करना चाहता हूँ, उनकी लाइफ ईजी करना चाहता हूँ। We are not MPS patients, we are MPS warriors.
So we saw how this video showed the collective voices of children with rare disorders and how they are coming together and trying to bring in a change. So if such children can, we can also. So now we move to an expert panel discussion, and our aim will be to provide maximum information to the parents and the doctors, and we'll be happy for questions at the end of it. So my first question in the panel is to Dr. Ratna. And ma'am, are you here?
Yes, I am here.
Good evening, ma'am. So the first question is that what are rare diseases and what are the prevalence of these diseases in India, and what are the treatment options we have available at present for these?
Okay, so thank you very much, Veronica, for the putting together the panel discussion. And I would also like at the outset to thank RDI and Sanofi Genzyme for this excellent opportunity to create awareness for rare diseases. So what rare diseases are is that they are actually disorders that affect a small percentage of the population. And we know that we have about 6,000 to 8,000 rare disorders, and about 80% of them are genetic. And what's important to understand is they can manifest early in life or even much later in life. Now, all over the world, we have different definitions for rare disorders. So the WHO says it affects 10 or less people in a population of 10,000. The US says that it affects about fewer than 200,000 people in the world. The European Commission says that it affects about 1 in 2,000 people. So on an average, we see that 1 in 6, except for WHO, which is about 10 of 10,000 people. So where we have disorders where there are less than this number of people affected, it comes under the umbrella of rare disorders. The prevalence in India, we don't know because we don't have a registry. We don't have a definition for rare disorders. But as most of us know, and as I would like to tell all participants of this panel discussion, is that the ICMR, along with the Ministry of Health, have floated a rare disease registry, and which is now in its second year. And I hope that, and actually not I hope, the whole aim of this registry was that with this, we will have some sort of a pattern of understanding of what is the prevalence of rare disorders in the country. So that more or less, I think, answers our first question. And what the government said was that based on what concept and ideas we get out of the registry, we will try and make a definition for rare disorders in India. What are the treatment options for rare disorders? We've seen a sea change in the last few years. In fact, earlier on when I started my career, it was a challenge even to diagnose rare disorders. And we know in India, all of us who are working within the rare disease space, that we have more or less conquered this challenge, and we have diagnosis for rare disorders that is available. And now the second thing that we have seen change over the years is the treatment options. Initially, we considered all of them untreatable, or there were treatments available and they were not available to our patients in the country. But now we know that we have treatment for a large number of rare disorders. It is from just changing a simple change in a diet, like we have for small molecule disorders, like galactosemia, tyrosinemia, phenylketonuria, etc., to enzyme replacement therapy for some of the metabolic disorders like Pompe, Gaucher, MPS 1, MPS 2, MPS 6, Fabry disease, just to name a few. And we also have now for MPS 4, alpha mannosidosis, and we have patients all over our country who are receiving treatment for this. But we also know that this treatment is not accessible to all our patients, and that is where we really want to achieve. And additionally, we have other forms of therapy like which target the genes, like we have for DMD and SMA. So there are many, many treatment options for rare disorders. And I want to tell everybody that it's not easy for patients all around the world to receive the treatment. We always feel that only in India we are not getting it. There are different avenues that are available for treatment for patients in different parts of the world. And even there are a lot of challenges. And we first have to understand what are our unmet needs, what are our challenges, and then address those challenges one by one. So really, that's what I want to discuss about, what is a rare disorder and what are the treatment options that are available for these.
Thank you so much, ma'am. That beautifully summed all the treatments that are available for rare diseases at present. Now we move on to the next question to Dr. Ashok. So, sir, in your experience from the recent years in leading rare diseases initiative in Rajasthan, do you think that it is important to focus on these disorders and them being so rare, or do you think and how do you think we can achieve that focus among the physicians and the public in general?
Thank you, Veronica, for your question. And at the outset, once again, I'd like to thank RDIF to have taken such a great initiative. And because for people like us, rare disease is in the core of our thoughts all the time. And it's really important that we need to focus on these disorders, because for all these years that medical education has been focused on was to think of common disorders. And that was the kind of teaching that I think most students, when they went through their MBBS and doing their specialization and super specialization, that think of a common disorder first, and then as a last resort, go on to the rare disease. And the net result is across the world, not only India, across the world, there's been a big time lag between the onset of the disease and diagnosis of the disease. For example, even the US, the alpha-1 antitrypsin deficiency, which has almost 100,000 patients, has a time lag of almost 7 to 8 years before the patient gets a diagnosis. So, and some of these disorders, especially the disorders as they are all progressive in nature, and as they progress, they reach a stage of non-reversibility, means you have a permanent damage across multi-organs in the body. And so that what happens is when the training is not focused on identifying rare disease early, you are going to get into a situation where you have a much larger load of patients who are non-treatable, and that's going to be a big social burden. And already, for example, we have a lot of LSDs, and there's been a fair delay in getting them the treatment, and the net result is whenever the treatment is available, they already have had multiple issues which may not revert. So early diagnosis is important, and that's where I think as a policy, even the government has to create a clear-cut policy. And not only from the perspective that it's a rare disorder, the point is that this word rare is confusing. It's if you look at them collectively, they are not rare. And as you initially said, yes, almost 79 million or 80 million people, or Saurabh said, almost 80 million people in the country suffer from one or the other rare disease. So it's almost as common as any other common disorder. And I think that focus is certainly required with such a large volume of patients.
Thank you, sir. And it is certainly, when collectively put, not so rare. Thank you, sir. Now we proceed to the next question to Dr. Rajesh, sir. So as a pediatrician, what are the common rare diseases do you see? So it is like an oxymoron, the rare diseases which are more common for you. And as a leading children's hospital in Jharkhand, do you think that the change in your practice and approach to these rare disease patient is required, and what has been your experience with these patients?
Thanks, Saurabh, for inviting me. And he's from Jharkhand, and he has worked here, and his child also is under treatment under one of my colleagues, Dr. Shailesh. And over the years, our hospital, first of all, I'll tell you that our hospital is basically a referral center. It's a 250-bedded hospital, and all of Jharkhand and nearby states, Bihar, Odisha, Chhattisgarh, Bengal, the children come here. So we get a lot of complicated patients in our hospital. If you go at present, also we have almost 3 patients admitted with us. One is SMA, and 2 are congenital myopathies. And we have sent exome sequencing from them, and still are waiting for the results. And as such, if you see, the awareness of this rare disease has increased among the pediatricians. And we also at our hospital, we had discussed the government rare disease policy 2 months back at our hospital. And if you go by my experience, and I will categorize as government classifies them as group 1, 2, and 3. Group 1 is basically for them one-time treatment you do and you forget, and the disease is cured. Like if we have a bone marrow transplant for viscous allergy, or bone marrow transplant for Fanconi's anemia, we will see, or like organ transplant. Once you do organ transplant, it is over. Like tyrosinemia or glycogenesis, GSDs, all these things are there. GSD is also quite common setup here. And second category group of diseases, we commonly we all know that those who require long-term treatment, either supplements or dietary modification or medicines, like as simple as growth hormone therapy, simple is like this, or we have continuous treatment like IVIGs for XLA, or as simple as diet modification like severe allergy, severe CMPI. This is also classified by the government as rare disease, severe CMPI, or inborn error of metabolism, like if you have MSUDs, if you have propionic acidemias, we have galactosemias. These are the common diseases what we see. And among the group 3, where the treatment is very costly, and for them, some of them we are proven. We have there are enough studies there to prove that they are efficacious, like MPS, and some of them like very costly drugs, but still the trials are not enough to say that they are 100% effective, or we need to conduct more studies like SMAs or maybe DMDs. So these are the common diseases. DMD is one of the very common diseases, and SMA. These are two very common diseases we see in our hospital. And change of practices over the years, like now people have become aware. We are doing previously, like when I was doing MD, I know that way back in 94, 95, that time we used to flip the pages, that's all. And for the writing the exams answer, we have to just remember the market. So what is it like? We have to add the answer. That's all. There was nothing practical, only theoretical. But nowadays, over the years, now we are diagnosing it, and some of them we are treating it also. We are giving prognosis to the families. So there are a lot of change over the years in the practice of rare disease, and even the poor states like Jharkhand, we have done a lot.
That's great, sir. So I'll just add a little more question to this. So what about a diagnosis followed by prenatal diagnosis in the next pregnancies? Is there awareness among obstetricians?
Yeah. This also, like we advocate this, and prenatal diagnosis many times, like SMS. When we diagnose, we tell the parents about this. Even the obstetrician, they are aware. Even the city like Jharkhand also, we are doing antenatal diagnosis, which is available, and we are doing it. And the awareness is also slowly increasing. It's not enough, but still awareness is increasing.
Thank you, sir. Now we move on to the next question to Dr. Priyanshu. So, Dr. Priyanshu, can you tell us that the importance of newborn screening in early diagnosis and management? And we are very happy that you've established an NBS program in your city as well. And how successful is it? And what are the challenges you've faced? Because convincing a family to do newborn screening is one of the harder things, we all know. And do you think it has helped family members pick up rare disorders? And is that testing, the timing, and what all tests do you do? Is an expanded newborn screening worth it? So what are our views on this?
So thank you, Dr. Veronica. So definitely newborn screening is very important in early diagnosis and management of genetic disorders, because as we all know that in newborn screening, we can diagnose some inborn error of metabolism and other disorders before the onset of symptoms in a newborn or infants. So when we are diagnosing these patients in asymptomatic state or early state, and we are giving proper treatment, so the disability can be limited with newborn screening. So it's very important to have a newborn screening program in place across the country, and it should be, if possible, it should have expanded newborn screening program. Currently, we are having newborn screening program only for 3 disorders: congenital hypothyroidism, congenital adrenal hyperplasia, and G6PD. And it's very successful. We are screening almost 25,000 newborns every year. And it is definitely helping the patients. We are diagnosing congenital hypothyroidism almost 10 to 12 patients in a year, and congenital adrenal hyperplasia around 15 to 20 patients in a year, and 2 to 3 galactosemia patients. So these patients are now under treatment and follow-up, they are showing good response.
Okay. That is really great. So you have patients with galactosemia who were picked up on newborn screening.
Yes.
And what are the challenges do you face? Like, our families, do they agree easily? Do you also counsel them about the expanded screening, and any differences you observe in the government setups? How do you counsel them for taking up the test?
Right. So we have a team, and we have three different hospitals which are attached to our Jekyllon Hospital, Gangwari Hospital, Janana, and Mahila Chikitsalaya. So there are pediatricians and neonatologists. So they are counseling the families whenever the family is not agreeing for newborn screening. So initially we started for only from the 10,000 newborn per year, but now gradually we are doing for 25,000 newborn. So there is a good pickup rate that clearly says that now there is more awareness among the families. So parents are coming and they are opting for, they themselves are insisting for newborn screening.
Right. So, and what is the pickup rate of expanded TMS-based screening? Do patients get that done as well in your center?
So we have done a study under guidance of Dr. Ashok Gupta sir 3 years back. In that study, we screened 99 newborns. Those were high-risk newborns. Those newborns were admitted in an ICU. And we got 7 positive out of 99. So it's a quite good number.
Very high, yeah.
Very high.
To be very high. This is a TMS-based screening?
TMS-based screening.
So,
Yes.
but 97 out of 99.
99.
So these
Yes.
were including all the disorders.
Including all the disorder. Out of these, the four were maple syrup urine disease. One was propionic acidemia or methylmalonic acidemia. One was CPT1 deficiency, and one other was urea cycle defect.
Right. Okay. That is a big wake-up call then. If you have a 7% rate, that is quite high. So now we come again to Dr. Ratna. Just sorry, 1 second. Yeah, now we come to Dr. Suvarna, and for her, we asked that we also understand the importance of teaching and discussing about rare disorders with students, and working in a medical college. How much of this actually happens, and how do you think we can achieve our need to educate young doctors? And also, what are the efforts being undertaken by the government in your area to spread some awareness of for these rare disorders? Dr. Suvarna, please.
Thank you, Dr. Veronica and Sanofi and RDIF for this wonderful opportunity of discussing about the rare diseases here. And as I started practicing rare diseases since last 3 years, I found that as a pediatrician, where I must be seeing 1/3 of my patients as suspected underlying genetic disease, my acumen of diagnosing rare diseases increased only after the fellowship in Nizams, and so it really needs an eye. If the mind knows, only the eyes can identify. So as a faculty in medical college, if I am aware of how to diagnose rare diseases, how to counsel, then I can create the environment or inculcate this attitude amongst the undergraduates and postgraduate students. Before this CBME curriculum, which MBBS curriculum has changed recently, before that only first year and second year MBBS students had some knowledge, theoretical knowledge about rare diseases. They used to learn about Down syndrome, some deletion duplication syndrome, thalassemia, sickle cell. And in third year, they may have some clinical postings, but still the focus will be more on the nutritional and infections and not the rare diseases. And they will only learn some, again, MCQs for PG NEET entrance. And as they go to specialty, broad specialties, super specialty, again, the focus is on their other non-rare or non-genetic diseases than the genetic diseases. But as I understand, the pediatric super specialty is blooming. There are fellowships and there are DM programs and all, like MD and then DM programs for the super specialty, subspecialties also. We see that the genetics is gradually spreading its leads to the all the specialties. We see the patients in all the specialties. So this training of suspecting a rare disease, diagnosing a rare disease has gone haywire, or maybe it is much with a lesser impact as I see right now. But on the same at the same lines, the work from the medical geneticist in India is definitely reaching to till the grassroots. These fellowships by Sanofi, the DM program, the fellowships by a few of the institutes, they are definitely making a mark in the map of India on rare diseases. And I see that when I get trained, my PGs get to see the patients, my PGs get to learn how to suspect, how to diagnose, how I can counsel when they listen, and what treatments are possible. So when I started with MPS enzyme therapy, Gaucher, so this is all happening here. Many, almost 15 IM patients are under treatment since last 2 years. So students, especially the PG students, are definitely seeing patients, how they are treated or how they are tackled. And for undergraduates, now this CBME curriculum is coming. The new curriculum definitely addresses, even in the third year, a lot of thrust on the rare diseases, the genetic diseases. So for undergraduates, it will definitely make a difference. And I think before the layman, the physicians, especially pediatricians, obstetricians, broad specialty and super specialty, all of us need some special training, some special sessions apart from their specialty only on genetics. And all the specialty people are started sending NGS investigations without understanding much. And I see that the patients come with VUS reports. And so I think though this markets are also increasing for the NGS tests and all the microarray and all the genetic tests, I think the knowledge and when to use, when not to use is much more important. And I feel that much can be done on this.
Thank you so much, Dr. Suvarna. That was a very important message, that only people with adequate knowledge are supposed to be ordering these tests. And so exome sequencing, I guess, has become like another CBC testing, which is now being ordered. And maybe it is a great idea to incorporate some sort of genetics in the pediatrics curriculum as well, right? So at least the basic when to refer knowledge is attained, right? Thank you, Dr. Suvarna. Now we come to Dr. Ratna ma'am. Ma'am, what are the challenges faced by these patients with the rare disorders? And I think you've already answered the treatment questions about the treatment. So what are the challenges in view of the disease itself, and also in view of obtaining the treatment for the children with rare disorders?
When we talk about the challenges, it starts from the birth of a child with a rare disorder in a family. So that itself, there is a lot of denial. We call what is referred to as a diagnostic odyssey. And there are some rare disorders which have been alluded to, which are not so rare. So generally, somebody who has been exposed, like Dr. Suvarna discussed, and also Dr. Rajesh also talked about that, yes, because they have been exposed to these disorders, they are able to make a diagnosis. Now, we have diagnostic facilities that are readily available, but it's also important to understand that you require different kinds of tests for different disorders. So even though exome and clinical exome and all this is available, there are many disorders which can be diagnosed by cheaper tests. And we have many projects all over the place. And if they are aware of where the projects are, we can even diagnose them much, free of cost for the patients. Because in India, we know that everything is an out-of-pocket expenditure. Even in the public hospitals, genetic tests have to be paid by the patients. So I think it's very important to understand, like for SMA, you would do an MLPA test. But really, if you're not sure whether the patient has SMA, you would do the PCR test, which is cheaper. Once you confirm SMA, then you need the MLPA test to do the copy number variant analysis for the SMN2 gene, which is a mandate for the various therapeutic options that are available. So I think a little information about the kind of test, the appropriate test, what can be missed by a specific test is important. And once the doctors appreciate the kinds of tests that are available and what is the right test in the right clinical scenario, I think that the challenges that are faced by the patients and their families become less, because they don't have to spend so much on repeated tests, and they are guided to do the right test within the right clinical scenario and at the appropriate cost. So that is for most of these disorders, and everything is not just doing the molecular test. So if we suspect Gaucher, so you have a child who has splenohepatomegaly, and most of them initially are neurologically mostly normal, and they have a lot of failure to thrive. You think of Gaucher along with thalassemia, you would just do the HPLC and you would do the enzyme test, which is free of cost under the initiative of Disha. So I think that is enough initially to align to a specific diagnosis, and then you do the specific gene mutation study. And here also, depending upon what the clinical diagnosis is, you can do just the common mutations that are known in the country. We have enough data of the mutations for the common rare disorders in India. And if these are not present, then you would go for larger tests. But beyond that, we have many disorders which don't fit into the realm of the so-called common rare diseases. And there, then they undergo many genomic tests. They can undergo a clinical exome, a whole exome, and they still don't reach to a diagnosis. And within this, then we can take them into the undiagnosed diseases program, where we have 3 centers in the country, Gangaram, SGPGI, and CDFT Hyderabad, where they are enrolled within the program and they undergo further genomic tests within a specific pattern of a clinical correlation with specific what we call HPO, human phenotype ontology terms, and then doing the appropriate genomic testing. So it really starts with the awareness of the physicians to address the challenges for diagnosis, because diagnosis is important for therapeutics and diagnosis is very important for prevention, which I think in a developing country is more of a key than being able to provide therapeutics. Until we have a correct diagnosis, a prenatal testing and counseling for recurrence risk is not possible. And as Dr. Suvarna said, the VUSs are not to be taken into account for prenatal diagnosis. So we have to do a lot of correlation. And now we are also at stages of doing functional studies to be able to confirm a VUS for a specific family. Well, treatment challenges are there because it's not available off the counter. They are very expensive. And we know that we have a rare disease policy, which I think would be discussed later. So some of it would be available through that. Some of them are available through programs of reimbursement by where the family is working. So we have to work out different things for different families. We don't have a ready platform where we can say, okay, go there and you'll get treatment. We also have to align and prioritize that for who is treatment going to be beneficial. I think that is also very important when we have limited options available for reimbursing treatment. And it doesn't sound good, but that is how it is done world over, that which is the child who would maximize the benefit of the therapy, and accordingly the therapy is prioritized.
Thank you so much, ma'am. That was very insightful. Ma'am, another question is about the cost of the testing. And if there is a family who cannot afford testing, can they be accommodated in the undiagnosed disease program? And what sort of tests should they bring to you for admission into your UDP project?
So the undiagnosed disease program it's a program which is for patients who have undergone some kind of genomic test. Say you have a child with intellectual disability or developmental delay. They've either undergone a microarray or a clinical exome, and no diagnosis has been arrived at. So the main aim of this program is that anybody can apply. The patient can apply, a physician can apply to the program. We have an email. We have, in fact, in one of the coming Indian pediatric perspective issues, I've written a little perspective on the program. How do we get included in the program? And I will put up a slide here also. I mean, I can just share the email where anybody can apply for the program, along with the detailed summary of the patient and whatever genomic details are available. Because here we are taking a detailed phenotype, we are incorporating that, we are even doing genomes free of cost in this for the family, or trio exomes, depending upon what the clinical scenario is and what we think is going to help us make a diagnosis for that family. So anybody who is suspected to have a rare genetic disorder and diagnosis is not available can apply for the program.
Thank you, ma'am.
I will put the email into the chat box to apply for.
So on this email, anyone can approach ma'am for the undiagnosed disease program, and it gives a hope to a lot of people maybe who cannot afford testing. Thank you so much, ma'am. The next question is to Dr. Ashok, sir. So can you suggest a model to provide access to diagnosis and management of rare disorders, keeping in mind the rare disorders policy? And what is the role of support groups that are now coming up as well? So if you could tell us a bit about the rare disease policy and a model to provide access to diagnosis of this.
Well, as the rare disease policy as it stands today, it has categorized diseases into 3 categories. The category 1 is diseases that have which are amenable to one-time treatment, and the disease 2 category is one which has a long-term treatment but still not very expensive. And the category 3 is a group of patients who would require long-term treatment and they're very expensive treatment plans. So, and the government of India has put under the Rashtriya Arogya Niti a fund of 20 lakh rupees to be used for one individual patient. For the category 3, where the funding is not directly available, the government has suggested that a mechanism of crowdfunding needs to be developed, and wherein this fund is generated either for in the name of the patient, him or herself, or in the name of the as a just as part of the CSR corpus going to the crowdfunding program of the rare diseases. And so this fund can be generated, and people need to apply, and on a priority basis, based out of the seriousness of the disorder, the emergent need for the treatment plan. The treatment is provided to these patients, and so it's an open access program where people can individually apply. So the government of India is creating a framework wherein over a period of time, I think we'll have more and more rare disease patients getting the benefit of the financial support that's seriously lacking. One. Number 2, the model of how do you have individuals having an access to diagnosis and management of rare disease? The point is, which has been raised by almost every other speaker, is
I think sir got disconnected. Maybe we can move to the next question and come back to sir. So the next question is to Dr. Rajesh, sir. And the question is that how has the scenario of treatment changed over the years for rare diseases? How have you seen the emerging treatment, people of children with SMA getting treatment, children with MPS receiving enzyme replacement therapy? And how has that changed overall how we really look at the rare disorders and them changing from a stigma to something that is really treatable? And another question which you partly answered is a busy practicing pediatrician. How do you think we can increase awareness among the primary care physicians? Do you think we will be ever get them to understand that these disorders are to also be looked at, or the common disorders first theory is always going to be in their minds? Thank you.
As we have already discussed that over the years, the treatment options have increased over the years in our country. And as simple as like the amino acid disorders, like MSUDs, we did not have a special formulas almost 20-25 years back. We used to import, and then we had formulas getting imported now legally. And now even the Indian companies, manufacturers, they are coming up. They have come up with their special formulas, like one tin of formula of imported ones costs around 4,000 to 5,000. But coming up, the Indian manufacturers, the price has come down to almost 1,000 rupees per tin. So it has made a lot of difference if you have manufactured the drugs or the formulas locally in the India, cost comes down. And also, like treatment scenario, people are taking treatments like these regular IVIGs for immunodeficiencies. Now people are going for, when my 2 patients have undergone bone marrow transplant for Biscott Aldrich. So, and the liver transplant was one of my patients had undergone transplant also. And also over the years, like one of the patients comes regularly getting a biphosphonate for osteogenesis imperfecta. So over the years, people have accepted that there is a treatment available, there is a hope, and people are for the treatment, even though they know the limitations of the treatment. Even among the physicians also, there is now acceptable acceptance that still treatment is there, so we can try. And even we cannot fully cure some of them, but some of them we can help them. And this is very important. Second question, how to increase the awareness among the primary care physicians? Not primary care physician, among the pediatricians. Right. Pediatricians, if you tell them what is microarray, what is whole exome sequencing, what is clinical exome, what is MLPA, they don't know. Right. They don't know when to order all these tests. So it will be very important to have regular CMEs for the pediatricians to tell them how to diagnose, what all tests to send, first of all. Because I see here also a lot of unnecessary tests being done. Simple, like if you have SMA, they send a clinical exome, like that. So not like that. So we have to increase the awareness among the pediatricians and the physicians, what is to be done. And if you diagnose, what are the treatments available, and tell them to properly refer them whenever they diagnose, to refer, when to refer, how to refer, what is the rate policy, which are the centers we are doing free of treatment, what government support is there. All these things are not known to the primary care physicians. Right. We need to have a regular CMEs to tell them, to educate them about all this.
Thank you so much, sir. Dr. Priyanshu, would you like to also give your experience on how do you want to increase awareness among pediatricians in your area? Any ideas you would have?
So definitely we need to aware pediatricians more and more. So for that we can conduct teaching programs, teaching sessions, and the structured training programs for a few days. For that we can get collaboration with government. So because in such like in Rajasthan, there are two different government programs. One is DMHS, Directorate Medical Health Services, and second is medical education. So we can collaborate with the Directorate Medical Education authorities, and they can structure a training program so that the pediatricians, those who are working at PHC, CHC or district hospital level, they can visit our center and they can get training and more exposure for rare disease patients. So that can be done. And secondly, definitely the role of MBBS and MD curriculum is very important. When we are giving training to MBBS and MD students, and we are making them aware about the rare disease or genetic disorders, so they will go to the periphery and they will practice there. They can diagnose more number of patients. They can refer to the whenever needed. They can refer to the Center of Excellence or State Center for Rare Diseases.
Right. Thank you so much. And I totally agree with you that it is important to also tell them the importance of referring when considered, because it's not always possible in a busy pediatric practice to order those genetic tests. Okay. So Ashok sir, we come back to you. I think we had lost you because of...
Yeah, I had a power failure.
Yes, sir. Okay. Now you're outside. Great, sir. So, yes, sir. So you can continue, sir. Thank you.
Yeah, the point that I was trying to raise at was that how did we get into it, and finally what happened was while we were working on the development of a rare disease program, because there were two clear groups in India at that point of time. One was a group of pediatricians and primary care physicians, and then genetists. There was a big gap and there was no overlap, whereas to promote or to get a much larger number of patients getting identified, we had to sensitize the primary, the first level contact, which was pediatricians and the primary care physicians. So we started working on it, and then we realized we did not have a definite text on that. So I and Priyanshu, we worked together and we developed a textbook on rare diseases for pediatricians and primary care physicians, making them understand what is the value of each test, where do you order this test, how do you do that test, and what is the interpretation, and what are the, and making them aware that this information of where to send a sample, how do you collect a sample, and then what are the therapies available at this point of time. So that's the kind of information that was required. And so if you look at the kind of research that we were able to produce from an institution where we've been doing rare disease now 8 years down the line, so it has sensitized our postgraduates. So across the state of Rajasthan, we now have at least 150 people who have a bigger sensitivity on the concept of rare disease, and it's really moving fast. So create educational inputs through medical colleges, the departments of pediatrics, and through putting rare disease in the curriculum at the undergraduate level.
Okay, thank you so much. And sir, that is some really commendable work. And I'm sure that book would be useful to all the pediatricians who are practicing at present. Thank you, sir. So now I think we're done with these questions. So now we come on to Dr. Ratna ma'am again, and ask her to please throw some light on the rare disease programs that are ongoing in India. I think ma'am, you already spoke about some of them.
Yeah, so as a program, we have many centers that are involved, and we have Dr. Ashok Gupta and Priyanshu who are doing a lot of work. So I'm actually happy to say that in most of the states, we do have some programs that are running, and in the form of, it started with a lot of grant from ICMR and DBT, where it helped, like we had the lysosomal storage disorder initiative that was taken by the Department of Health Research, where there was a lot of capacity building even in centers which did not have molecular tests and now have been able to establish the molecular tests through the program. And a lot of data collection happened through that, a lot of awareness happened through that. And similarly, so really in every state, there is one center, at least one center of excellence where these programs are happening. And now with a lot of awareness through the parent support groups, as well as through some of the funding agencies, a lot we are seeing is happening. And we also know that the Department of Biotechnology, the DBT, is running an UMEED program. And in that UMEED program, there is a lot of hand-holding on how to write the proposal, on how to submit the proposal. and how to develop basic facilities, for example, for diagnosis, for newborn screening, as well as for prenatal testing. So it's taken all the three important components of creating awareness, making a diagnosis, preventing recurrence, as well as newborn screening, at least for hypothyroidism and congenital adrenal hyperplasia. These are the mandates, and these are mandates for any center who wants to develop a genetic unit. And I'm happy to say that through this program, there are many centers in the country who are developing facilities that. It also includes the training. We also have, through the Society of the Indian Academy of Medical Genetics and Sanofi Genzyme, we have 3 months training program. I think it's through that training program, maybe Dr. Suvarna was exposed at Nizam's, because they are at different centers, and these details are available at the website of the Society of the Indian Academy of Medical Genetics. And I do know that the Indian Academy of Pediatrics, as well as the Society of Fetal Medicine, are doing a lot of work to develop these programs all over the country.
Thank you, ma'am. And we know you are doing the most work to develop these programs as well. So we're thankful for that. The next question is to Dr. Suvarna. I'm sorry, I'm not able to change the slide. So the question to you, Dr. Suvarna, is, are you here, Dr. Suvarna?
Yes.
Veronica, you can give the question and just unshare your screen and share it again, and I think it'll move. Yeah.
I'll just, So the question is that what are the, because as you work in a medical college, so what are the challenges in a government sector that you face, and how do you get your patients to undergo testing because of the high cost of the testing technologies, and what sort of setup do you have at your center in the diseases you are managing?
Okay. Yes. Thank you, Dr. Veronica. So I really feel that I work in a medical college, and I feel that it's an asset for rare diseases, overall treatment and all management is concerned. I have a lot of opportunity to teach undergraduates, postgraduates, and big opportunity for awareness. That is one thing. Secondly, this patients referred to even this tertiary care center, they require many visits and require a lot of time. At least the primary physician to identify the problem, not in my pediatric department, but in general, patient comes with a big file with a lot of investigations from many visits from other doctors or other physicians. And then if like the consultation with the genetic expert, or like when I see the patient, then mostly with the counseling, they do get some answer. And cost is definitely an issue. All the genetic tests are definitely costlier. So the test, depending on scenario, definitely will be sending like single gene mutation or MLPA or whatever that TP-PCR, whatever is required as per the disease identification. Because of the consanguinity and many IEMs and single gene diseases are common in my region. Almost 45% of the consanguinity is there in my region. And so the NGS test, next generation based technique, is mostly utilized here. Though I see a lot of Down syndrome or chromosomal structural abnormalities also. So the labs have a special tie-up with the hospital that they give me testing at an affordable rate or at a lesser cost to patients, especially undergoing tests through MGM Medical College, which may be different for outside corporate hospitals. So that is one thing. And even my college also supports through subsidizing the charges for rare disease patient. I do get a special sanction from Dean office for my patients that if there are treatments and all are required or long stay. So both the patients with Gaucher and MPS, nothing was charged from MGM Medical College as a hospital stay or medication charges and all. And I'm very proud about that. So in all, my Dean, my MGM Medical College is fully supportive to this program or this work on the rare diseases. And nowadays the costs are coming down, but still there is a lot of issue about costs and affordability, especially try and all I have to send, or so it's a problem. So I tie up with CDFB or CCMB and get the test done.
Thank you so much, Dr. Suvarna. And we are very happy your patients are getting free of cost therapy for such expensive treatment-based disorders. So I'll just try to share my screen again. So the next question is to Dr. Ashok sir and Dr. Priyanshu, that what are your views on the various fundraising organizations and how do patients really reach a fundraising organization? Can they do it directly, or is it better to do it through their physicians and geneticists? Your views, sir, Dr. Ashok sir.
If you really talk in terms of fundraising, there are two important components. One is a medical professional, if he's got some kind of connections, because quite often we have people coming to us and they're looking they want to do charity, because most people have absolutely no idea where to go and whom to go. So they know the medical consultant, and so some of them come to us and offer some kind of, they are willing to do charity if there is a patient who requires financial support. But the point is the volume of that funds are usually not very, very large. The kind of money that we require for enzyme replacement and other costly treatment. So for diseases where you need a treatment plan of say 10 lakhs, 20 lakhs, 30 lakhs, people are there to do a one-time donation. But then the second important group, because it is the category 3 of these rare disease policy patients, where you need more money, and this money has to come through crowdfunding. And the crowdfunding, the mechanics has to be made. Means this information is has to be very clearly worded out. Clearly, people should know what is the intention and what is the mechanism whereby they can go in for crowdfunding. There are many private organizations who have come up, and if you have you need to have a whole directory of these people available to at least rare disease people working in the field of rare disease, so that they can connect them, because it's a highly professional approach that you need to do, because they know how to send information. They have a database of people where the information can be sent. So it's a professional approach, and I think we need to look forward to organizations involved into crowdfunding.
Thank you, sir. Dr. Priyanshu, your views on the same?
So I think everything is covered by Dr. Ashok Gupta sir. Just to add, there are few private organizations like Keto, Impact Group, and Milab. They are also doing crowdfunding campaigning for a few of the patients.
So do you have a personal experience with these? Do you think it's easy for parents?
Yes, no, yes. So it's easy to reach them, but it's very difficult to gather funding from these platforms. It's really difficult. However, few of the patients got up to 16 crore rupees for Jolja and SMA also, but they are very few.
Okay, I think it'll be useful if you can give out some names on the chat for parents to also get in touch with. Thank you. And now we have, I think, our final question to Rajesh sir, that we keep on talking about the costs that are morbid, that are almost impossible to be taken care of. So what is your thought on the ways we can try to bring down those costs? You did talk about these drugs being produced in India, but that is still a little bit of a future dream. So what do you think the government can do, or how do we involve the government and convince them to be a part of the rare disease policy, more in the treatment scenarios?
So treatment scenario, like we have those who are leading people in this field of genetics and this rare disease. They should have a proper platform for advocacy, and also they should interact with the government. Like I was talking to the Jharkhand government officials here, they get the fund every year, but for last 4-5 years, not a single paisa has been given to anybody. So they don't know how to spend it, and policy made by the government, the state government, respective state government, and they can have a list of diseases, just like maybe the
I think we have lost Dr. Rajesh. So now we will ask the. Okay. Sir, are you here?
yeah.
Okay. Yes, sir.
So
Please.
I was telling that we have to talk to the state respective health officials or those who deal with the policy making decisions at the government level. We have to convince them to make a policy respective state and to formulate a guideline, fixed guideline, and a written guideline, which are the diseases they will cover, state will cover. Although we know group 1 disease can be covered by center, the group 2 disease has to be covered by the state. They should come out with the list of diseases which can be covered, and the information can be disseminated throughout the pediatricians and even the general practitioners, so that they can refer the patients, and they shall also know where to refer and how to refer to the government to get the grant. That can be done easily.
Okay, thank you so much, sir. Now, finally, we have a question for our founder of this organization. And we would like to know from you, Mr. Saurabh, that what is the vision of RDIF and what is the plan and actions of the steps taken to help the care of the rare?
Yeah. The vision of Rare Diseases India Foundation is to raise awareness in the country. Awareness not only in the patient, but in the general public too. Awareness to sensitize the decision makers and the stakeholders also. Also to focus on early diagnosis, newborn screening and genetic counseling, to advocate for stronger policy support, to support and strengthen national patient registry for reliable rare disease database. We also collaborate with important stakeholders that can strengthen the cause of rare disease.
Thank you so much, Mr. Saurabh, and we hope and wish you all the best in your vision, and that we all are with you. And now I will request all our esteemed panelists for their final comments, and so we can start with Dr. Ratna. Ma'am.
Okay, so I think where we talk about rare disorders in India, it starts with education, awareness, and making a correct diagnosis. And I feel that India is a large country. We all practice in large cities, each one of us in this panel. And I think that what happens in the smaller cities is that the patients are missed. They are recurrences, even for simple disorders like SMA, what we see in our clinics on a daily basis. So I think if we just start with creating awareness and making a diagnosis, that's a big step ahead.
Thank you so much, ma'am, for your time also. So Dr. Ashok, sir, your final comments.
I would just say that, yes, we really had very nice discussion this evening, and the focus for me is going to be more to train, sensitize primary care physicians and pediatricians, because that sensitivity, as it grows, we are probably going to see a big revolution of getting more and more patients getting diagnosed early, and so that they can be safe and healthy.
That is the hope, sir. Thank you.
Yeah.
Dr. Rajesh, sir, your comments.
I will continue the same Dr. Ashok said, that we have to sensitize and the primary care physicians and pediatricians, and we have to conduct regular CMEs for educating the pediatricians about how to diagnose and what are the treatments available and where to refer.
Okay, thank you, sir. Dr. Suvarna.
Yeah. So the disease policy in place in India, it is so much creating hope that patients are going to get treatment. And when pediatricians, apathy is because one of the reasons for apathy is that they are not treatable. We are not going to do why to diagnose them. So this issue will be resolved, and I feel that the future is bright for rare disease children, group 2, group 1, and all of them. And I feel that's a great happening now.
Thank you, Dr. Suvarna. Dr. Priyanshu, your final comments. Dr. Priyanshu, are you here? Okay, so I don't think Dr. Priyanshu is here with us now. So finally, I'd like to summarize and conclude.
Veronica, can I just give one comment before you summarize? I think we all as pediatricians have a basic responsibility to make a definite diagnosis during the life of the child. I know that many of our children cannot receive the treatment if it is available. Most of the diagnosis we make is not it's not a good diagnosis for the family. But I think it's worse if during the life of a child we don't make a diagnosis, because when they come back to have a second baby, we are still nowhere, and unfortunately they end up having a second affected child. So I think this is what we really have to even tell our fellow pediatricians, that it's very important. Very often we tell the families, we can't do much, it's an untreatable disorder. So they don't want to take the effort and spend the money to make a diagnosis. But I think we all realize why that's so very important.
Thank you, ma'am. Absolutely. And every child deserves that diagnosis. That is absolutely essential. And thank you everyone for your invaluable knowledge that was provided today. And I have myself gained so much from this webinar today. And I think the take home points for all of us would be that we now have the starting of a registry for rare disorders at 3 institutes, as told by Ratna ma'am. It's at Gangaram Hospital, at SGPGI, and at Genzyme. And that registry, it has to be made available in more centers as well. And it is important
Veronica, the registry is in many centers under
Right.
the ICMR thing. It's in many centers. This is the undiagnosed diseases program.
Right.
Registry is ongoing at about 40 centers in the country.
Okay, so that is good, and that's how we will know the prevalence of the rare disorders, because we have that registry now. And everyone should try to make their children who are diagnosed with the genetic disorders a part of the registry, so that whenever there is a treatment, these children can be reached out to. Now, there is an undiagnosed rare disease program as well, which is actually available at these 3 centers, and the contact is present in the email as given by ma'am. And we know that there is a need of educating pediatrician, and also we did not mention too much, but educating obstetricians is also very important, because a lot of these malformed children, malformed fetuses first go to the obstetricians. So it is very important to conduct CMEs and get into the curriculum of MBBS and MD to increase the part and the significance of genetic testing in them, and also to make pediatricians and primary care physicians aware of the different tests that are available and the interpretation of that testing, which is much more important. And a beautiful example was given how a exome sequencing was sent for SMA, and exome sequencing is not the end all test. And finally, the presence of all the treatment that is available and all the great support groups and advocacies like the RDIF that are present and helping these children, and the correct timing for referral is most important for these children, so that we do not lose the window of treatment. Finally, I would like to now invite Mr. Saurabh to take the program forward and just say that though the diseases are rare, the hope should not be rare. Thank you so much.
Thank you, Veronica. I would request Mintu to play a second video. Our IT team to play the second video.
Lysosomal storage disorders, or LSDs, are a group of inherited metabolic diseases. Each is caused by one or more mutations that results in the deficiency or malfunction of lysosomal enzymes. Lysosomes are organelles within cells that contain multiple degradative enzymes, which serve to break down different types of biomolecules. In most LSDs, due to the reduced activity of functional enzyme, the lysosome's ability to break down complex macromolecules is impaired. These large, undigested molecules then accumulate within the cells, eventually leading to cellular and tissue damage. LSDs are progressive and over time may lead to increased disability and premature death. For these conditions, timely diagnosis is important in respect to optimal disease management. To assist with accurate diagnosis, dried blood spot (DBS) testing is available. DBS tests are easy to use, inexpensive, and reliable for testing if the following simple guidelines are followed. Firstly, all data fields on the DBS card must be completed for each patient. Dried blood spot specimens are obtained by collecting and applying whole blood to specially designed specimen collection paper. In patients over a year old, whole blood is most commonly collected through a finger prick. The blood should be applied to each circle on the DBS card. The blood should cover the whole circle. Laboratories may also accept samples collected by standard venipuncture. Blood can often be collected in EDTA tubes, but the performing laboratory should be firstly consulted. Collect venous blood in a collection tube and immediately invert the tube to mix the additive. Blood can be transferred using a pipette under the appropriate safety equipment. Hold the pipette tip above the center of a circle close to the surface but without touching it. Gradually discharge the blood and let it soak into the paper, filling the circle completely with a single application. Repeat the procedure for all remaining circles of the filter paper. Incorrect sample handling may lead to false positive results or sample rejection. Therefore, make sure the blood is properly collected. To preserve enzyme activity, samples must be dried at room temperature for at least 3 hours, away from direct heat or sunlight. To avoid cross-contamination, do not stack cards. Cover samples after they are dry. DBS specimens are classified by the International Air Transporter Association, IATA, the World Health Organization's Guidance on Regulations for the Transport of Infectious Substances, and by the International Civil Aviation Organization as a non-regulated exempt material. This makes DBS easy and safe to be shipped by regular mail when your local regulations and institutional policies for packaging and labeling are followed. DBS-based tests enable quantification of enzyme activity and easy sample collection. Positive DBS results should be confirmed as per local guidelines, often by either enzymatic activity on white blood cells from venous sample or tissue and/or genetic analysis of the suspected lysosomal storage disorder. Lysosomal storage disorders, or LSDs, are a group of inherited metabolic diseases.
Yeah. Thank you. Thank you so much, doctor, speakers, and the panelists for joining us today to discuss our topic today. So, once again, thank you so much, everyone, our audience and our sponsor and our strategic partner for participating for this great noble cause. Thank you.
Thank you.
Thank you.
Thank you so much.